run through some of the questions. I know some of you are getting stumped on some of them, and so we'll just talk about the images for the most part. Question 2 on the test, it said based on the pathology of this image, it can be assumed that this is a carcinoma that has medsed into the lungs. And the obvious answer was yes. And the reason you can tell that it had medsed into the lungs and it was not a primary carcinoma of the lungs is because of the rounded appearance. They are virtually round. And anytime that you see meds into the lungs, they're going to look round. Any other appearance, such as a regular shape, lobulated shape, kind of jagged on the edges, that is primary carcinoma. And then everybody did pretty well on this one. You just had to do simple division. This one was pretty obvious for everyone since it was pneumothorax. This one kind of stumped some people as well.
I missed this on the quiz too. What am I missing?
What are you missing? Okay. Aortic aneurysm and hemothorax. The reason it is an aortic aneurysm is because it has been injected with contrast, and if you look here, this is aorta. And so you can say that this is bigger than what it should be, and so you can just assume that that's an aortic aneurysm. And then if you look here, you see that it's a hemothorax simply because you have fluid levels here, fluid level. And that's why it would not be a pneumothorax, and it wouldn't be a pericardial effusion because you don't see enough of the heart to actually be a pericardial effusion. You can't tell whether this person has one or not. So does that make it a little clearer?
I thought I answered that, and I thought I missed it. I thought that I answered A for that. I thought you marked my wrong.
It shouldn't be on your one. I'll go back and look at it.
Okay.
It should, if it did. But that's what it is. A lot of people were putting hemothorax and pericardial effusion and things like that. And then we get to this one. This one says this image represents primary lung cancer, not metastatic disease. And the answer is true. And the reason you can say this is because it's not entirely round. And if you look inside of it, it's kind of difficult to see, but you see a little bit of air here, here. And one of the things about primary carcinoma of the lungs is that it has air bronchiograms in it. And so that's what those are. Anytime you see air and a very lobulated appearance on it, that is primary carcinoma. And then I think everyone did pretty well on this one. It was pretty obvious to just about everybody that it was emphysema. So I don't think there's much need to cover in that one. And this one, I think a few people got confused. And the reason this is B, type A is in your ascending aorta that is immediately coming out of your heart up into your aortic arch. And then type B is when it is descending into your abdomen. And if you look at this image very closely, you see that you're going out of the lungs and into the diaphragm, and you're actually seeing liver come in. And so, based on that, you can assume that that is a type B aortic dissection.
I'm glad that's right, because that's how I looked at it.
Exactly. Okay, and this one, this is exactly the opposite of what the other question was. This would actually be classified as a type A dissection. But the question was not whether it was a type A or type B, but whether it was an aortic aneurysm or not. And because you see the line running through the aorta, it's safe to say that this is an aortic dissection. I think everyone did well on that one. This was another one that got everybody kind of confused. I think a lot of people put TB, and the reason it is not TB is it has air bronchiograms in it, and it also has a lobulated appearance, meaning that it's not smooth, but it's more jagged on the edges. And it's attached actually to the chest wall. And so that even further demonstrates that it's lung cancer. And primarily, when you see TB, it's up in the apex, very top of the lungs, and we're down a little deeper than that. And so that's what makes this more along the lines of a malignant lung mass and not TB. This one, I think everybody knew what they were supposed to be clicking on. Whether you could click on it or not, that's a different story. So I think I wound up giving everybody 2 points for it, even if you weren't able to click on it. This one, once again, people had a little difficulty with it. And people put generally either lung mets or pulmonary fibrosis. And the reason this is not pulmonary fibrosis is you do not see the honeycomb pattern, nor should it be emphysema because you don't see the big alveolar air sacs with no definitions of thick walls. And it's not lung mets because it's in both sides. And another clue to looking at this image is that if you look at the bottom where there's stars, that is bilateral pleural effusions. So if you know that this person has bilateral pleural effusions, that means that this person is probably in some type of cardiac failure. If the person's in cardiac failure, then the heart's not able to pump the fluid out effectively, and so thereby you have fluid pulling into the lungs, into the alveolar air sacs, as well as pleural effusions. So that is how you can kind of justify that. Okay, this one, once again, kind of stumped a few, but this is actually a type A and type B because it starts at the aortic arch, so this would be type A, and then probably right here to right here, that's type B. So you actually have both of these going on at the same time. This one is a pneumonia. It's not bronchiectasis. You don't see any bronchioles that are large or in the same diameter as the arteries that are next to them. You don't see pulmonary fibrosis. You don't see a honeycomb pattern. And on top of this, you see positive air bronchiograms, air going through it. And it looks kind of patchy and splotchy. And so you can also rule out that it's not lung mets because it's not round. And so that means that the only answer that it could be would be pneumonia. This one kind of stumped some people as well. And this is a pericardial effusion with a pleural effusion with probably some pneumonia layering on top of it. It's not actually a hemothorax. And the reason it's not a hemothorax is because you have bilateral. And so it'd be very, very traumatic to have bilateral hemothoraxes. And so you should have seen rib fractures, something like that. So on this case, it'd be more safe to assume that it's a pleural effusion and not a hemothorax. And on this one, this is actually bronchiectasis. And the reason you can tell this is because you have this over here. And if you look right next to it, there's an adjacent artery, and they are actually bigger than the adjacent artery. And so it wouldn't be emphysema because you're not seeing the alveolar air sacs. It wouldn't be anything like that. It wouldn't be a pneumonia, but it would be bronchiectasis because you see the dilation of these. And that is the surefire way to tell bronchiectasis. And then we get to the bonus. And what I was looking for on the bonus, based on what I had wrote here, and I had even highlighted the important things that you should have looked at in bold. And in bold, you see that it's a 28-year-old male, been smoking for 4 years, labored breathing, no history of lung disease, things like that. You hear diminished breath sounds. Based on that, and you ordered a D-dimer and all that, and it came back negative. Based on what you see on this, you should be able to see that you should order an ABG, a chest x-ray, and then look at the chest x-ray to see if there are no lung markings. If there's no lung markings, then you order a CT chest. The CT chest will then verify that there are no lung markings on it. And based on that, if you see no lung markings, you automatically know that it's a pneumothorax. But what clues you in further is that it's a 28-year-old male with a history of smoking, prime candidate for a spontaneous pneumothorax. So to achieve the full 6 points, you had to tell me an ABG, chest x-ray, CT chest, and you would receive half the points. And then you had to tell me that it was a spontaneous pneumothorax. Not a pneumothorax, because a pneumothorax can range from tension pneumothorax, spontaneous pneumothorax, things like that. There can be varying degrees of it, but based on the symptoms and the patient's history, you can say that he is a candidate for spontaneous pneumothorax. I had to know that it was a spontaneous. And so if you told me that it was a spontaneous pneumothorax, then you got full 6 points. So that's where we are on that. So with that being said, let's get into the gastrointestinal system. Does anyone have any questions about the test? Okay. All right. And the gastrointestinal system is one of those systems that I don't feel is as hard as what we have covered, but there are some things like Crohn's disease versus colitis that will get difficult, that will get confusing, and hopefully we can kind of make it a little better to understand, a little easier. With that being said, just a general overview of the gastrointestinal system. I'm sure you guys all know how it all works, and I'm sure it's been drilled into your head by now. But you have your teeth, then tongue, salivary gland, goes down your esophagus, reaches your stomach, goes out of your stomach, goes into the duodenum, jejunum, ileum, goes into your cecum, goes up the ascending colon, transverse colon, descending colon, sigmoid, and then out your rectum. That's just a simplistic overview of everything. And then you see here just a further, more detailed diagram of the colon. And I apologize for these. I actually inserted these today. And so these are not really that important. So they're not going to be tested over this. But we're just going to get a generalized overview. It's pretty simple. And you also see an accessory organ, the appendix. And that will play an important part into the gastrointestinal system, because you will see when you're doing CTs, there are going to be a lot of cases that are for appendicitis. That's just one of the more hot topics. Everybody that comes in that has right lower quadrant pain automatically, instinctively thinks that they have appendicitis, and that's not always correct. It's actually a misnomer. But one of the more simple things that you'll see in the abdomen pelvis, in the gastrointestinal system, is ascites. And the word ascites is from the Greek, and it's from ascos, which means sac or bag. And ascites describes a condition, a pathological condition of fluid building up in the abdominal cavity. That's simple as it gets. When you see fluid in the abdominal cavity, you automatically label it as ascites. And healthy men have little to no abdominal fluid. They have no fluid at all. However, women, depending on their time of the menstrual cycle, may actually have up to 20 milliliters of fluid free in their abdominal cavity. And so it's normal for women, but not normal for men. But anything over 20 milliliters for women, depending on their period in the menstrual cycle, will actually be an indication of something further going on. And so we see that there's several different types of ascites. We have exudative ascites, which is just typically associated with inflammation going on in the body. And this inflammation can be pancreatitis, peritonitis, or just bowel perforation. And peritonitis simply means that it's inflammation of the peritoneal or peritoneum. And we also see that there's neoplastic ascites, which is caused by a neoplasm in the abdominal cavity. And then we have colitis ascites, which is caused by an obstruction or traumatic injury. And it says to the thoracic duct or cisternae chili, but what you really have to take away from this is the thoracic duct and the cisterna chili is a part of the lymphatic system. And so anytime that you have obstruction or trauma to the lymphatic system, it can cause fluid to actually go out into the abdominal cavity. And so that is what you see here. Those are the three main types. And if I'm not mistaken, maybe your book will go into further detail if there's more types than this, but these are the three types that we will focus on. And so ascites just simply represents a state of total body sodium and water excess. And so they don't actually know what the event is that actually causes this. There are three theories of the causation: underfilling, overflow, and peripheral. And we're not going to go into massive details about this because they're still pretty unsure about what is actually going on here as well. But what you need to know, underfilling occurs because of portal hypertension. The portal vein that runs into the liver that is taking blood away from the stomach, from the intestines, and also the spleen that empties them into the liver. There's a problem there. Overflow is caused by renal insufficiency, meaning that your body is not letting go of the water as it should be. And peripheral, it's simply just a combination of all of them. It's a combination of underfilling and overflow. And that's as far as we're going to get into that.
The overflow was caused by what?
Overflow is actually caused by renal insufficiency. So hypothetically, someone who is in renal failure, you would normally see this exhibited in them. But once again, these are just hypotheses, and they're not actually something that they have proved. These are just simple theories that they think could be causing it. Because in the grand scheme of things, we still don't know what is causing something as simple as ascites. And for the most part, people associate ascites with liver failure. That's what portal hypertension kind of is a symptom of, is liver failure. And people who have cirrhosis are generally thought to be the ones that really exhibit ascites. However, it can be exhibited by other things, such as I've saw patients come in that have been having right lower quadrant pain, and you scan them and they have had an ovarian cyst and it is ruptured. And because the ovarian cyst is ruptured, it's caused free fluid in the pelvic cavity. You know, there's other causes of this besides just cirrhosis and liver problems. But the associated symptoms here most of the time is associated with liver problems. And so you see jaundice, palmar erythema, and that is just reddening of the palms. And reddening of the palms is in conjunction with cirrhosis. You also see spider angiomas, and this is also related back to cirrhosis of the liver. So if you want to look at that first line there, you can just write cirrhosis by it. Also, an enlarged liver, you can have an elevated jugular venous pressure, and then a Sister Mary Joseph nodule. And this Sister Mary Joseph nodule is usually found in people who have malignancies and metastatic disease, things like that. And it is part of the lymphatic system. But this is not an indication of someone who has ascites. This is just kind of an accessory thing, and not something that if you don't feel it, you can say that the person doesn't have ascites. And so the workup is just pretty simple. Chest X-ray, abdomen, flat and upright, simple acute ab series. You see an elevation of the diaphragm, and that equals massive ascites. 80% of the patients have the Helmer sign, which is the lateral edge of the liver being medially displaced or pushed in from the lateral margin in towards the center of the body. So we also see that ultrasound is a nice exam to do. It can display up to 5 to 10 milliliters of fluid, and is very, very easy to do. It's not something that is very traumatic for the patient. We also see a CT abdomen pelvis, and then we also have a simple evaluation. A lot of times ascites can be diagnosed by the physician going in and pressing on the patient's stomach. And when they press on the patient's stomach, they can either classify these in stages. Stage 1 is detectable only after careful examination, so if they really take their time and really know what they're looking at, they might be able to find it. This this is pretty much indicative of a low-grade ascites. Stage 2 is easily detectable, but of relatively small volume, meaning that you can actually detect it, but it's still of a low volume. Stage 3 is obvious, but not tense. And so basically, you can still press on the abdominal cavity. You don't see the tension that normally would exist. Stage 4, the patient is very tense, and so it's labeled tense ascites. This is the most severe. These are the type of people that you will see when you scan them, that they'll have tons of fluid all throughout their body. And so, with that being said, this is what ascites actually looks like. If you'll see, this is probably an indication of what a Elmer sign would look like. If you see on the lateral edge on the right side where the liver should be almost extending out, there is this big, huge space. But this space is fluid. And this fluid is actually going all the way around the liver and circling around, and not just around the liver, but you also see it on the spleen. And so this person has a large quantity of fluid in their body, just free fluid that is floating around. And an additional note on this patient, if you look at the liver, and you see all these little things here. If you look at that and just look at it for what it is, this person probably has carcinoma of the liver. And this person is actually probably going into liver failure. So this person probably does represent some of those that have jaundice and things like that because of the liver failure. We also see that it doesn't just have to be up around the liver, it can actually be down in the pelvis. And if you see here, we've got all of this, and that is free fluid in the pelvis. That is actually probably someone who has had possibly an ovarian cyst rupture or something like that. And you would see fluid just accumulating in the pelvis. And this, the tape that is performed, this has actually done a measurement here, and it's averaging about 15.00 Helms fluid units, which is the standard unit of measurement for CT, just tells you how dense it is. And so you don't have to classify ascites as just being up in the upper regions of the abdominal cavity. It can actually be in the pelvic cavity as well. And I don't know if you can see it. You're kind of losing definition on this. But one thing that I've noticed on patients who have tons of fluid building up in their system is if you look into the fat, you can kind of see it over here, but primarily it's along the back side. If you see a person that has tons of fluid building up, the fluid is actually seeping out of their skin. And you can actually see the fluid, it'll be like a haziness here. If you get home and look at it, you might be able to see it. I can see it on my screen, but you're kind of losing it here. But take a look at the bottom of that, see if you see some type of haziness. And that just kind of cues you in that the person does have ascites as well.
Does it weep out of their skin or come out like sweat, or do they even notice it?
Some do and some don't. I had a really good case of it one time. She was about 26, 27. She had been diagnosed with ovarian cancer, uterine cancer, and it had mets all over her body. And she had been taking treatment. They had done all the surgery, they had done everything. They thought they had got it. And so she went probably about 3 months without having any symptoms. She comes in, and I think it was the day before Christmas that I was working, and we did a scan on her, and it had come back. And from that point on, she just steadily went downhill. And I think within a year, she was gone. But every time she would come in about once every month and get a scan, they just want to see the progress of it. And she would have haziness going down here, and then along the lines, she would start having tons of fluid build up, and they would try and go in and drain it, but they'd never be able to get it off because it just keep coming back. The next scan you do, she'd have more haziness, more fluid, more everything. And so when you see someone like that, you can really start associating the haziness down at the bottom with the ascitic fluid. when you get home, or when you get a chance to use the computer, take a look at this image and see if you can see the haziness at the bottom. That's just a good example of what sided fluid can do. So, does anyone have any question in terms of the sightings? Okay. Well, we'll go into an abscess now, which is a little more difficult than ascites. And so, an intra-abdominal abscess are typically a localized collection of pus that's confined in the peritoneal cavity by an inflammatory barrier. And so, that is just a simple definition of it. And you see that the abscess usually contains a mixture of aerobic and anaerobic bacteria from the GI tract. And if left untreated and the process continues, bacteremia will occur, which will lead to sepsis and then into shock. And so, if an intra-abdominal abscess is allowed to continue for an extended period of time, the patient will actually develop sepsis, possibly go into shock, and then die. And so, this can be a very serious condition. And so, if we just look at the simple microbiology standpoint, we see that the aerobic organisms that are involved are E. coli, and the anaerobic organisms are Bacteriolus, Frigili, and a synergistic relationship exists between them, meaning that one on their own probably couldn't cause the abscess, but them working together, it can actually cause a weakness in the immune system and allow an abscess to form. So it takes maybe 2-3 types of bacteria to actually create an abscess. And so we see that the most common cause of intra-abdominal abscesses are perforation of diseased viscus, perforated appendicitis, and diverticulitis. And this is a big one that people worry about when you have appendicitis, that if you allow it to progress too long, it will actually cause a perforation. And once that perforation exists, all the bowel contents, all of the inflammation kind of gets out of hand and goes in the body. And so appendicitis can turn into something that is deadly simply because of the perforation, if it's not caught in time. We also see a gangrene cholecystitis, bad gallbladder persisting for too long can cause this. Mesenteric ischemia with bowel infarction, and then pancreatitis or pancreatic necrosis. And that is another one that I'm sure you guys will see. Pancreatitis, it's quite common. Actually on Sunday I did a CT on a lady that did have pancreatitis based on her lab work, and we confirmed it with CT. And she hadn't got to the extent of developing an abscess, but the possibilities were there for her to develop it. And so the symptoms that you'll see are just persistent abdominal pain, and that's quite nondescript in terms of everything that we're going to be talking about, because most of these symptoms can present with abdominal pain. Also focal tenderness, spiking fever, that is a really good indication that something in the immune system is actually going on. Prolonged ileus, leukocytosis, mild liver dysfunction, and persistent GI dysfunction are all symptoms that can be related to an abscess. And so, looking even further, the workup for diagnosis is just a simple CBC and lab work. That is really the only thing that is going to tell you that something is going on, such as an inflammation. Because if the white blood count is elevated, you can assume that there is an inflammation process going on. Abdominal films are rarely diagnostic. You would probably do them just to rule out things such as bowel obstructions, but in terms of abscess, you're not going to see anything. You also see ultrasound, and the accuracy rate for ultrasound is very high. It's around 90% or greater for an intra-abdominal abscess. However, we also see that ultrasound is operator dependent. So if you have someone who is not as skilled as another person, then potentially you could miss intra-abdominal abscess. So that is something that is concerned. And that's what kind of makes CT a little better in this case than ultrasound. And so you see greater than 95% accuracy rate, because CTs are readily available, and also because they're not as much operator dependent. there's not as much opportunity to miss something because you're going to catch everything that's in your scan fluid. And so if we look at just the CT manifestation, we see that it generally appears as a localized fluid collection of around 10 to 40 counts per units in attenuation, and they may resemble encapsulated ascitic fluid. And they often have internal debris, fluid-filled layers, septations, and even air fluid levels. We also see that they have a definable wall with a regular thickening, and they're often associated with ascites, pleural effusions, and lower lobe pulmonary infiltrates. So there's other things that go along with this as well. And so here's what an abscess actually looks like. And one of the really good indicators for abscess is you'll see stranding in this area. And so this is probably actually someone who may have appendicitis, may have an actual ruptured appendicitis. It didn't really say when the place that I got the image, but just based on the location being on the right lower quadrant, this is someone who probably could have some abnormalities with the appendix as well. But that's not really what we're focusing on. The key to an abscess generally is you see all of this stranding here. And I realize that we lose a lot of definition by going with this projector, but when you get home, also look at the stranding here. You see a wall here, and that's the encapsulated wall. And I don't really think that you see any air fluid layers or any fluid on fluid layers, but you do see the encapsulated wall, and you do see the stranding. And so, coupled with the location, the stranding, the encapsulated wall, and probably the white blood count, you can be safe to say that this person has an abscess. But just looking at it from CT, you can say that based on the straining in the wall, that this is an abscess. However, here's another abscess, and this abscess actually has an air fluid layer on it. And that's what this is actually pointing to. You see here the air portion and then the fluid portion. And then this one has an encapsulated wall as well. It's very defined. And it also has stranding as well, originating on it. And so, based on this person has an abscess as well. And this is just another portion of the same skin. You see again an air fluid layer, and this time you don't see as much straining. However, you do see some haziness here. And then, based on the location, the air fluid layers, things like that, you can say that this is an abscess. So does anyone have any questions about abscesses? Those are some of those things that you don't see quite often. I don't think I've saw many abscesses at all. It's just not something. The only time that I've saw an abscess has been when the patient has had an acute appendicitis and they refuse to either come to the doctor when the onset of pain happened and they allow their appendix to rupture, or they have actually the case of one person, they had appendicitis, the doctor in the ER misread the report that the radiologist sent them home, and then they came back out. Mm-hmm. And then they had a ruptured appendicitis. And then they had developed an abscess. But that is about the only times that I've actually seen an abscess. So we'll go to diverticulosis, diverticulitis. I'm sure you all have talked about it when you've been going over procedures and things like that. And I'm sure you have a pretty good indication of what this is. And so diverticulosis simply describes small sac-like outpouchings of mucosa and submucosa through the muscular layers of the wall of the colon. And so if you want to think about this, the way that I would tell you to think about it is that it's like a hernia. When you have a hernia, your intestines kind of push out through the abdominal wall. And when you have diverticulosis, the mucosa and submucosa kind of herniate. They push out of the muscular layer of the intestines and kind of create these little pockets outside of the intestine. And so we see that primarily, it increases with age, with it being rare in people under 30 years of age. And I don't really know how well that holds up in today because, you know, all the time they're finding other things that cause diverticulosis, diverticulitis, Crohn's disease, irritable bowel syndrome, things like that. And so I don't know whether that is completely accurate or not, but for the most part, we'll just say it is. And so we see that if the neck of the diverticulum becomes obstructed with feces, food, particles, or inflammation, we see that diverticulitis results. And so diverticulosis is just simply the outpouching is developing, and diverticulitis is the inflammation of those outpouchings. And we see that if this inflammation is not treated, is not held in check, this can actually spread to the other outpouchings and next to them and create widespread diverticulitis. So that is just diverticulosis, diverticulitis in a nutshell. And so, for the most part, they don't really know why diverticulosis, diverticulitis occurs, but it is presumed that it occurs because of the high pressure that is exerted in the lumen when straining to pass a bulk of stool. And you see this probably if someone is constipated and they're having difficulty actually moving their bowels. This is a prime candidate for someone who will have diverticulosis and diverticulitis. And so we see that the associated symptoms are just, many times, patients don't have any symptoms until they actually have a flare-up. But when the patient actually has a flare-up, we see that they can have intermittent lower abdominal pain, which is frequently worse after eating or when stressed. And we see that stress is a prime factor for diverticulosis and diverticulitis. People who get stressed out, they tend to have a flare-up. We also see that there's alternating bouts of diarrhea and constipation. This is one of the really big symptoms along with the abdominal pain. That you have alternating bouts of being constipated and then having just spontaneous diarrhea for no explained reason. And so the workup for this is laboratory tests such as CDC, which can demonstrate an elevated white blood count, metabolic panel, urinalysis, which is very important to rule out a urinary tract infection because it could be mistaken for diverticulosis or diverticulitis, although the pain is actually stemming from a urinary tract infection, which could then cause an elevated white blood count. So it's very important to get this. Also, we see a blood culture. It helps rule out septicemia. And we also see CT abdomen pelvis, MRI, small bowel follow through, coupled with a barium enema, an EGD, and colonoscopy. However, what I have found from most of the research is the EGD and colonoscopy should be withheld until the diverticulitis is in check. When the person is actually having a flare-up from the diverticulitis, it's a very, very bad thing to go in and do a colonoscopy, simply because you run the risk of rupturing one of the diverticuli and then creating an abscess, so it can really get out of hand quickly. So the CT manifestation of this is that the diverticuli are easily visualized as small, rounded collections of air, feces, or contrast material outside the lumen of the colon. And you see that they range in size from 1 to 2 millimeters, or 1 millimeter to 2 centimeters. We also see that acute diverticulitis is demonstrated as a colon segment with wall thickening, hyperemic contrast enhancement, and inflammatory changes that extend into the pericollic fat. Simply meaning that when you have acute diverticulitis, you'll see some straining coming out of the outpouchings as well as the outpouchings being exerted. So here we see someone who actually has diverticulosis, diverticulitis, probably along the lines of diverticulosis because it doesn't seem that there's any straining that is actually coming in. But if you look at the wall you see here, there is like a little round dot outside of what the lumen here would be. And also over here as well, you see these little bitty dots that have air in them. And that is actually a demonstration of diverticulosis. However, this is not one of the best slides for it. I believe that we have, I didn't actually have one that was better. But this one is something that you can see here as well. Right here is the actual lumen, and you see that pouches here, and they have air in them. And when we actually have a test, a quiz on this, I will make this very apparent to you. There shouldn't be any hesitation or confusion about what is being displayed. You'll see a very good image without pouchings. So does anyone have any questions about those? Okay. Small bowel obstruction. And small bowel obstruction is caused by a variety of pathological processes. The leading cause of small bowel obstructions in the industrialized countries is post-operative adhesions, around 60%. And I know on the third slide from this one, it will say 75%, but we're going to discard the 75% and go with this. I think the books kind of have a little competition going on with numbers. I noticed that some of the cases in this, that some say 75, some say 60, some say all different types of numbers. But to erase all of the confusion, we're just going to go with 60%. And we're going to say that the second leading cause is malignancy. Crohn's disease and then hernias, although some studies have reported that Crohn's disease is a greater factor than neoplasm. And so basically what this is saying, that people don't really know what the second leading cause is, but the first leading cause is surgical adhesions. So someone who has had problems that have required surgery on their small bowel, they have a greater chance of small bowel obstruction. And so one study from Canada reported a higher frequency of small bowel obstructions after colorectal surgery. We also see that small bowel obstruction leads to proximal dilation of the intestine due to accumulation of GI secretions and swallowed air. And so there are several different types of obstruction. You can see partial, complete, simple, and strangulated. A partial obstruction is that the patient appears to be obstipated but continues to pass some gas or stool, meaning that they have the symptoms of being a full-fledged obstruction, but nothing is actually going on as much as a complete obstruction. Complete obstruction is the exact opposite, meaning that the patient fails to pass air or stool through. A simple obstruction, and then we can see a strangulated obstruction. And this is the most dangerous. If left untreated, it will progress to perforation, peritonitis, and then death. And so the strangulated obstruction is something that they have to rule out very quickly, because if it is not ruled out very quickly, the patient will just steadily go downhill. And so the most common cause of small bowel obstruction is post-surgical adhesions. And you just take the 75% off, and we're going to negate that. And then where it says external hernias are the second most common cause, erase the second most common cause. And we'll just consider that as being another cause. And so we'll see that luminal occlusion, intrinsic lesion of the bowel wall, and external herniation as all possible causes of small bowel obstruction. But the most important to worry about is someone who has had surgery to the small bowel. And so when the physicians actually see the patients, that is one of the more important questions that they will ask, is have you had any surgery to your bowels? And that is an important question that we as techs can ask as well, to give the radiologist a heads up as being So we see that the associated symptoms are abdominal pain once again, and it's usually crampy and intermittent. And it is actually more prevalent in a simple obstruction than anything else. We see proximal obstruction is demonstrated as pain for a short duration with bilious vomiting. We also see a distal obstruction is pain that lasts for several days with abdominal distension. And other symptoms are nausea, vomiting, diarrhea, constipation, fever, tachycardia. And so the workup for diagnosis, CBC, an increase in the white blood cell count usually equals a simple or strangulated obstruction. The metabolic panel will demonstrate dehydration, which can be a possible cause for obstruction or constipation. We could also do abdominal fumes, which, interestingly enough, have a failure rate of around 30%. So there's a lot of people that put a lot of credentials into the abdominal fumes as being very good indication of whether you have an obstruction or not. But we see here that they have a failure rate of around 30%, so they're not always accurate. And another thing that kind of degrades the abdominal fumes is that they can't differentiate between strangulation and simple obstruction, meaning that if you have a strangulation, it can go unnoticed and just assumed as a simple obstruction, and then you get sepsis and possibly die. We also see an ultrasound, less costly than a CT, and may be reliable to exclude small bowel obstruction in as many as 89% of patients. And so ultrasound has a pretty decent demonstration rate. However, we see that CT is once again gold standard. It is 90 to 95% effective in the diagnosis of small bowel obstruction, and the good thing about CT is that it's 47 to 74% effective in demonstrating the causation of small bowel obstruction. And we also see that MRI is used, but the bad thing about MRI, once again, is that it requires a longer examination period, which then coupled with the possibility of strangulation can cause more drastic effects, and it's less productive than CT. So that is why we tend to use CT for small bowel obstructions. An intravenous contrast is recommended because it provides enhancement of the bowel wall, which allows you to better see pathological processes and the bowel wall. And so if you can see the bowel wall, then you can see what is actually going on as well. You can kind of trace things. We see that a complete mechanical obstruction appears as a dilatation of proximal small bowel with a distinct transition zone to collapsed distal bowel. So that's an important thing to remember. A paralytic ileus appears as a dilatation of proximal small bowel with it appears as a dilatation of both proximal and distal small bowel without a transition zone. So the key point in a paralytic ileus is that there is not a transition zone in comparison with a complete mechanical obstruction. A partial mechanical obstruction simply means that proximal bowel is less dilated and the transition zone is less distinct. And a closed loop obstruction, you look for the beak or whorl sign. So, small bowel obstruction looks something like this. You see tons of dilated colon. You see all of this is just completely dilated, and this is actually your small bowel, which should not be this big at all. It should actually be quite small, even with contrast or fluid or anything in it. However, this person is completely dilated, and this is someone who probably does have a little bit of contrast injected, because you can see the bowel wall pretty decent, and you can see where it ends, where it stops. However, in this situation, we don't see what is actually causing it to stop. We just see that it's completely dilated. But once again, one of the key things to demonstrating and finding out whether the patient has a small bowel obstruction is getting a good history from them and seeing whether they've been able to, go to the bathroom or not, coupled with their surgical history. If they've had surgical history of having things such as their small bowel worked on, as well as not being able to pass stool or gas, then it's probably a pretty good indication that what you're seeing is an actual small bowel obstruction. We also see here the small bowel is dilated as well, and this person looks a little worse than the last one. It looks like it's really dilated here. And this person, as you can see by the kidneys being lit up, that they have actually injected IV contrast. And another telltale sign of this being an obstruction is if you look here, you see that they have actually had oral contrast. And the oral contrast does not pass anywhere besides this point. And so if you see the oral contrast is stopped and you have dilation of the small bowel, then you can just assume that this person probably has a small bowel obstruction. And just on a side note, this person has a very dilated renal pelvis, probably a dilated ureter, probably has a renal stone just a little farther down as well. But right now we're actually focusing on small bowel obstruction. So does anyone have any questions about small bowel obstruction? Okay. We'll go to large bowel obstruction, and we find that it is an emergency condition that requires early detection and intervention. It is simply defined as an interruption of the flow of intestinal contents. So anything that disrupts the flow of intestinal contents in the large bowel can be labeled as a large bowel obstruction. And one of the biggest things about large bowel obstruction is trying to distinguish this from an ileus, and also ruling out non-surgical causes and determining the best surgical management for this, or if the patient needs surgery at all. And we see that large bowel obstruction is most common in elderly individuals, and this is due to the greater prevalence of neoplasm in this age group. And that will play an important role because we will see that most of the large bowel obstructions are caused by neoplasms into the colon. And that's primarily what will cause this. And so we see that it seems to be age dependent, with an increase as the age increases. We see that mechanical large bowel obstruction causes dilatation above the obstruction, which equals impaired venous and arterial blood flow to the bowel. But we also see that large bowel obstructions tends to be less acute than small bowel obstructions. And these symptoms develop more slowly, and we see that fewer fluid and electrolyte disturbances are noted. And so it's very difficult just looking at lab work to say that this person has a large bowel obstruction because there's really nothing that distinguishes it from any other. And so we see that 70% of large bowel obstructions are caused by primary colonic carcinomas. And so people who have colon cancer, this is probably how most are diagnosed. Most of the patients probably actually come in with symptoms of a large bowel obstruction. They do all of this lab work, they do the CTs, they do everything, only to find out that the large bowel obstruction does exist, but it's caused by a primary carcinoma of the colon. We also see that diverticulosis and volvulus account for the most other causes, but for the most part, we will just focus on most of it being caused by carcinoma of the colon. And so we see that while symptoms can greatly vary, some of the most widely noted symptoms are abdominal distension, that is a very big one. Nausea, vomiting, cramps in the abdomen, and a history of carcinoma of the colon. So someone who just comes in and they actually do have a history of carcinoma of the colon can automatically assume that they might have a large bowel obstruction. However, abdominal distension is another big thing to focus on. So someone who presents with a very large abdominal distension, that is someone that you could say could possibly have a large bowel obstruction. And so we see that we can order lab tests, such as CBC, metabolic panel, and a urinalysis, and that is for the most part the same reasons that you would order that for the small bowel obstruction. CBC, elevated white count, would be demonstrated, other things. Urinalysis to rule out kidney stones, urinary tract infection, things like that. We also see that a decreased hematocrit level is possibly a lower GI bleed. And then if you progress further into radiology, you see chest x-ray, abdominal flat and upright. Dilated colon without air in the rectum equals an obstruction. If you have free air, you have a perforation. And so that's one of the things that you have to be concerned about. If you see free air, then the patient does have a perforation, and that is a very dangerous condition for the patient to be in. We also see CT ab pelvis, but it's not useful in patients with a large bowel obstruction unless the diagnosis is still in question. So one of your books says that some professionals recommend a scan for patients without a history of surgery who have symptomatic signs suggesting infection, bowel infarction, or a palpable mass. And so some professionals, some doctors will say that it's very useful to order a CAT scan to demonstrate this. We also see endoscopy, and endoscopy is simply used for patients who have possible masses in their intestines, and you can very well demonstrate that. And endoscopy coupled with colonoscopy. And so, classic symptoms of large bowel obstruction on CT is really no demonstration, because CT is not generally utilized for a large bowel obstruction. This simply means that many times the causation of the obstruction will be found instead of the obstruction itself. And so, if you look at that last quote, what that means is that most of the time, if you order one for a large bowel obstruction, you'll go looking for a large bowel obstruction and find something else that will be causing the large bowel obstruction. So you won't find the large bowel obstruction itself, but you might find a carcinoma, you might find the outward pore lesion that is causing the obstruction, things like that. That's what you will actually find with CT. And here is an example of a large bowel obstruction. And if you want to look at it, this is the ascending colon here, and probably what you can see here is that there is a mass. If you look at where the contrast is flowing into the ascending colon, into the second lumen of the ascending colon, there is a very, very tiny gap here. There is a very large stenosis, and that is probably a neoplasm into the colon, and that is causing the stricture. And that coupled with the dilation of the ascending colon, but you see that there is no obstruction in the small bowel, because you have very, very adequate contrast being in it. And so you see dilation there. Here is also a large bowel obstruction, and this one is much harder to see. Here you see part of the bowel, but it looks all hazy, looks all fuzzy, and that is just dilated, probably with some infectious process as well as an obstruction. But this is not really the most adequate of images. The more adequate of the images would be the previous one, where you can see the dilated ascending colon and the stenosis. But if you just simply look at this one looks at looks more dilated in this area, but it's very difficult to see. So does anyone have any questions about large bowel obstructions? Large bowel obstructions and small bowel obstructions are one of the more difficult things to discern, simply because most of the time you don't ever get a heads up as well. We're just looking for an obstruction when doing the CT. We're looking for something else to cause that abdominal pain. And for most of the time, the physicians are simply happy with doing just normal films. And then you see airflow layers, things like that. That's pretty much what they do. They just do that, and then they say, well, that's the diagnosis. So most of the time, it never gravitates toward the CT. However, in the case of the small bowel obstruction, we see that possibly it should. All right. So one of the bigger things to get into is appendicitis. Why don't we take a 5-minute break? We'll split the hour and we'll be back before we get into appendicitis.